Kia ora, and welcome to this part 2 of our look at acute pulmonary edema of cardiogenic origin. So let's go straight into it. The reason for the formation of acute cardiogenic pulmonary edema is going to be left ventricular dysfunction. The dysfunction, whether it be of an acute nature, such as an MI, or a chronic problem, causes a mismatch between the output of the right and the left ventricles. One of the more common chronic reasons behind this is uncontrolled hypertension over many years. And after years and years of pumping against a high diastolic pressure in the aorta, the structure of the myocytes of the left ventricle start to undergo structural changes that's called remodeling, or sometimes referred to as myocyte slippage. Essentially, the myocytes lengthen and they lose their elasticity, so we end up with a thinner ventricular wall that can't increase its contractile force. Now, this remodeling uncouples the Frank-Starling mechanisms, and under normal circumstances, this mechanism enables an increase of the preload, that is the amount of ventricular filling prior to systole, to produce a more forceful contraction. In short, the remodeling process prevents the increased blood volume going into the ventricle to be able to increase the stroke volume or the amount of blood that's coming out of it. As the degree of heart failure progresses, it's actually more likely that an increased preload, or the amount of ventricular filling we have, will result in a worsening stroke volume. And in this slide, the blue line reflects the expected stroke volume increase caused by this increase in preload in a healthy heart. The orange line represents the diminished stroke volume and a shorter plateau of optimal performance that occurs in the presence of this remodeling. Ischemic heart disease will cause similar remodeling, but whatever the cause might be, once initiated, the remodeling will continue to occur and heart failure becomes established, and in essence, the process becomes somewhat cyclic. The net result is that the left ventricle cannot increase the stroke volume when extra demand is placed on the heart. Now, you might already recognise this, as many of the patients that we go to that have acute cardiogenic pulmonary edema have symptoms that are triggered by some form of physiological stress. So they might live with heart failure all the time, and then they get something like an infection with a fever that has increased their heart rate and their preload. As a result, they end up with the classical symptoms of worsening acute pulmonary edema. Many of us may have also seen the result of having a patient undertake physical activity in this setting, and the simple act of standing up or having to walk to a carriage chair or a stretcher can dramatically worsen the patient's condition and exacerbate the acute cardiogenic pulmonary edema. But back to these pressures or forces that are causing the actual pulmonary edema. Now, Starling's hypothesis was that there had to be a balance of forces between those that move the fluid out of a capillary and those that move it in. And in an ideal setting, this would mean no overall loss or gain to the blood volume. Starling's law of the capillaries states that the net filtration pressure, that is the amount of fluid loss or fluid gain, will be determined by subtracting the forces moving fluid out from the forces moving the fluid in. In practical terms, this means that the net filtration pressure is going to equal the blood hydrostatic pressure minus the blood colloid osmotic pressure. And in perfect circumstances, the equation would result in zero. I found the simplest way to remember what goes wrong in the setting of acute cardiogenic pulmonary edema is to think of a model where the output from the left ventricle is perhaps 1 mil less per heartbeat than it is for the right ventricle. So this becomes representative of the poorer stroke volume from the left ventricle than there is from the right. You might imagine what the outcome would be if the right ventricle is able to exit 70 mils of blood into the pulmonary arteries, while the left ventricle is only able to eject 69 mils out into the aorta. In this model, 1 mil of fluid enters the pulmonary circulation, but it's not able to exit. With each successive heartbeat, more and more fluid builds up in the pulmonary circuit. This increases the pressure, forcing blood from the pulmonary capillaries into the interstitial space of the lung, that is, all the gaps between the other forms of architecture like alveoli and the airways. So quickly looking at this again, we have our blood hydrostatic pressure forcing fluid out and our blood colloid osmotic pressure forcing fluid in. As the blood hydrostatic pressure forces its way into the arterial end of the capillary, it's going to diminish as it moves towards the venous end. However, the blood colloid osmotic pressure remains relatively consistent the whole way through, and so the two forces balance each other out. In the case of the left ventricular dysfunction, though, what we have is an increasing blood hydrostatic pressure being forced into the capillary circuit from the right ventricle that the left ventricle is unable to clear. And now the blood hydrostatic pressure has become greater than the blood colloid osmotic pressure, so the net filtration pressure becomes positive and fluid exits the capillary and remains in the interstitial spaces. This is the initial stage of pulmonary edema. Now, the effect of this edema is twofold. Firstly, it creates a barrier between the alveoli and the capillary surfaces. For this reason, it becomes more difficult for oxygen to diffuse from the alveoli and to enter into the capillary. So this can lower oxygen saturations and in severe cases will produce hypoxia. Secondly, we all of a sudden have a whole lot of extra weight of all this fluid being contained within the interstitium. So the effect of this is that it requires considerably more energy to expand the chest. In other words, it's going to become more physically demanding to generate the inspiratory pressures to move air into the airways, and breathing becomes quite tiring as a result. The sign associated with this increased work in breathing and the symptoms are dyspnea and fatigue. The next phase in the formation of this acute pulmonary edema is that the extra fluid within the interstitium will be forced across the alveolar wall and enter into the alveoli and the terminal airways. Now, this will give rise to the very common symptom we associate with acute pulmonary edema, which is, of course, the presence of crackles on auscultation. One theory that explains their existence is that extra fluid in the terminal portion of the respiratory bronchial terminal binds this bronchial close during the early inspiratory phase. And as intrapulmonary pressure decreases to the lowest point, so that'll be at the end of the inspiratory phase, many of these terminal airways are all going to snap open simultaneously. So the rustling sound that we associate with pulmonary edema could well be the collective noise produced by the sudden and late opening. Typically, this is going to produce a sound that is going to be inspiratory and it's going to be at the very, very top of the inspiratory cycle. This X-ray shows the presence of pulmonary edema. The telltale sign is the white haze that extends through the lower lobes of both lungs. Another clue is the distended mediastinum and the proximity of the cardiac apex to the chest wall on the left side of the picture. If the heart failure is the issue, both the left and the right pulmonary circuits are going to be affected, and thus the sounds and the X-ray results we see here are going to be bilateral. The tendency is for the edema to form at the bases first, and then, as the condition worsens, extend towards the apices. The further up the chest the sounds rise, the more advanced the ACPO is. So just to make these points clearer, let's compare this with an unremarkable chest X-ray. By comparison, the mediastinum and the cardiac silhouette look relatively normal, and you'll notice that the apex of the heart is now some distance away from the left chest wall. And none of the lung fields have that whitish opacity that's associated with all that extra fluid that's held within the interstitium and the airways. Now, in this example, we're looking at quite severe ACPO. We can see that the mediastinum and the cardiac silhouette and the lungs almost all the way to the apices are totally obscured by edema. So let's have a look at the classical presentation associated with this pathophysiology. If we're writing up an illness script, the first thing we would notice normally is that the patient is quite short of breath. And we know from a pathophysiological point of view, this is due to the increased weight and decreased compliance in the lung architecture associated with all the extra fluid. They have a symptom called orthopnea. So while they're short of breath all the time, this definitely worsens while they're lying down because it has reduced the efficiency of the respiratory movement, and it can worsen the forces that cause this translocation of fluid from the capillaries to the interstitium and from there into the airways. There's going to be strong sympathetic stimulation. People who've got heart failure, they're not going to have great output, and we know that putting extra demand on the heart can reduce that output even further. So we see people that have a lot of anxiety to the point they can appear quite combative or even aggressive, and they're going to present with a tachycardia and tachypnea. And of course, we're going to back it up with these respiratory sounds where we're going to hear inspiratory crackles, and we may hear these sort of wet rails as fluid starts to leak into the main airways, and eventually we can have frank edema. That is, we can actually see the edema coming out through the upper airway. So let's just have a quick recap. Whether the problem is an acute or a chronic problem, acute cardiogenic pulmonary edema results from increased blood hydrostatic pressure in the pulmonary veins. The cause of this is going to be left ventricular dysfunction. The increased blood hydrostatic pressure forces serum from the blood through the capillary walls and into the interstitium of the lung, making it harder to expand the chest, and this is going to result in dyspnea. The extra serum also creates a fluid barrier between the capillaries and the alveoli, and this makes it harder for oxygen to cross from the alveoli to the capillary, and it's likely to result in hypoxia as it gets worse. The fluid can cross from the interstitium into the smaller airways as well, and this produces those classic inspiratory sounds that we associate with cardiogenic pulmonary edema. And the classical presentation is a pale and diaphoretic patient with signs of poor perfusion and with respiratory distress. There is usually heightened anxiety, and the respiratory sounds are going to include a bilateral inspiratory crackle that will extend up the chest wall to the level of the edema. Overall, the severity of the presentation is best determined by using the perfusion status assessment check and the respiratory status assessment check. The worrying symptoms that we might see on first presentation are going to include a lowered level of consciousness, fatigue, refractory hypoxia, and the presence of frank edema. We're going to finish this section here, and when you're ready, you can go to part 3, which talks about management. Until then, ka kite.